So perfect. So, hello everyone, welcome back to the Tract-Anat Club. We took the break last month because Kiara and I were in Verona for the IST Winter School. It was a great 4 days with around 50 participants. So I hope that next year we can do the same winter school again somewhere else. Also, before we begin, quick reminder, since we are always looking for a guest speaker, if you know someone that's a tractography expert with an interesting story or subject or research, especially someone from South America, Africa, Asia, to like diversify a bit our reach, please reach out to me or Kiara. You can send us an email. I would put them in the chat with the name of the person you think of and maybe like one sentence on like why you think they would be great for the Tract-Anat Club, and then we'll contact them and try to get them as a speaker. Today, our invited speaker is Geert-Jan Rutten. He's a professor of computational neurosurgery at the Eindhoven University of Technology in the Netherlands. He's doing multidisciplinary research focusing on tumor and surgical intervention to see how they impact brain network, quality of life, and cognition. He will do his presentation for 25-35 minutes, and then we'll have a period for question at the end. If you want to ask questions, you can also write them directly in the chat, and we'll try to read them and try to answer questions after that. So that's all for me. So the floor is yours. Then go ahead. You shared your screen earlier. Don't forget to share it again.
I will share it first. Thank you very much, François, for the invitation and the opportunity to speak to this society. So let me share the slides. I hope you can all see it now.
Yes.
Okay. Perfect. So thanks very much again. So before I continue, I just want to say I'm very fortunate to work in the neurosurgical department in Tilburg and also to work with researchers not only from the hospital here, but also from the universities of Tilburg and the Technical University of Eindhoven. So it's really from this hybrid collaboration that this talk is the result. So I'm presenting on behalf of all the researchers here. We've been doing research for about 15 years, studying brain networks in tumor patients. And we're very used to use tractography in clinical practice before surgery to counsel our patients and also during surgery to guide us during the surgery and the resection. So we have a strong belief in I think in the clinical value of tractography, but there's, as you all know, there's still many problems and misconceptions and that need to be solved. And the first thing I want to state is actually that I think that tractography does not need to be perfect to provide clinically useful information. So here's a case from some time ago where we did DTI, and you can see this, I hope you can see my pointing device here. You see this yellow language pathway. It's the IFOV at the medial border of the tumor in this young patient with a glioma. And so we use the information during surgery, and as much of the tumor has been taken out, this guides us to the critical areas during surgery. So in this case, tractography helps us identifying critical structures and that we find with electrical stimulations, for instance. So it really heightens the awareness and gives you actually anatomy for free. So in this talk, I want to address three different questions. First, why do most clinicians still think locally and still assign functions to particular areas or structures, for instance? Second, I want to tell a bit more about electrical stimulation mapping, what the benefits are, but also what it actually measures and how we can use it for validation, for instance, of tractography. And some of the most important ideas on brain function, I think, are not new. So if you go back into history, and this is work of Carl Wernicke, and he actually stated that knowledge emerges from associations across modalities. So he was a pupil of Mindert who discovered white matter tracks in the brain. And Wernicke really said that brain function is a network phenomenon, as you can see here. But unfortunately, that was a bit forgotten, and in particular in clinical practice, there was a sort of a modular system adopted for functional areas in the brain. So functions really got reduced to areas on a map, as you can see here, a very mechanistic and static view, but still much used in clinical practice. And on the right-hand side here, you can see the classic neurological model of language that resulted from these post-mortem studies, and that show you an important area in the left frontal lobe, which was named after Broca, and an important language area in the back of the temporal lobe, named after Wernicke, with one connection between it, and that is the arcuate fasciculus. So a very simple, intuitive model that allowed doctors to point to areas and assign functions to particular areas. However, we know that the brain is adaptive and is very plastic, actually, as shown here by one of the researchers from our group, Wouter. And he showed if you have a tumor anywhere in the brain, that will change the connectivity not only locally, but also at a distance. So if you measure connectivity in the contralesional hemisphere, you will find that it has changed in brain tumor patients, and these changes also correlate to cognitive performance. And this plasticity, the adaptation of the brain can really be very prominent. And that is, and I will show you some examples from the clinic. So for instance, here, again, on the right side, is the classical neurological model. And here's the patient I showed before with the glial tumor. So a young patient who had a seizure, but no deficits, and in particular, no language deficits. So if you compare the MRI of the tumor and the location of the tumor to that of a classical language model, you see that's actually exactly located in Broca's area, but the patient didn't have any deficits. And so these patients, for a long time, these patients weren't considered operable because of the high risks. And we now know that you can actually remove tumors within classical language areas without lasting deficits in most cases. So this patient was operated under awake circumstances. We did find language areas, but not within the area of the tumor. And we could resect the tumor. The patient had temporary language deficits, but no permanent deficits. And so we have actually many examples of patients with tumors in classic functional areas. And this is a patient, again, a young patient with a seizure, no language or other neurological deficits. And the tumor here is exactly located in so-called Wernicke's area in the posterior temporal lobe. And you can even, in particular cases, remove tumors from the precentral gyrus, so from the primary motor cortex. Again, you can see here the tumor within the precentral gyrus, no functions over the tumor, but functions in the vicinity of the tumor. And you can remove the tumor, and you need to be careful because in the depth you will encounter passing language or other pathways that are actually then considered the functional border of the resection. So most gliomas are not, of many gliomas are not resected up to anatomical boundaries, but up to functional boundaries. So clearly the challenges in neurosurgery are that there's a very complex and dynamic relationship between anatomy and function, and that can very likely be further changed due to pathology. So in that sense, brain surgery is actually network surgery. And we very much need prediction models and tools that can tell us before surgery what the risks of surgery are and where these functional structures are located. So what is the tool that we have in surgery? That is electrical stimulation of the brain. And that's actually a very old technique. It's over 100 years old. And here you see a nice picture of Wilder Penfield in the Montreal Neurological Institute. What you see here is the patient is lying on his side, operated under awake conditions. So the scalp has been anesthetized, but there are no pain receptors in the brain. So the patient is fully awake, and he is tested I think by the anesthesiologist or the psychologist. And Penfield documented all his cases, and I think many of you will know, for instance, this image, which is the motor homunculus that resulted from his electrical stimulation data, actually. So if you compare that to the current situation, it's basically the same. So again, so on the right side, you see here the patient is lying on his side, local anesthesia. Here's our medical psychologist testing the awake patient. And on the left-hand side, my colleague looking through the microscope and stimulating the brain electrically while the patient is performing all sorts of tasks. And this is an example to show you how that looks like when you look through the microscope. So there's the bipolar electrode giving a small current to the cortical surface. The patient is awake and is performing certain tasks. So for instance, if you stimulate with electrical stimulation primary cortical areas, you will induce, for instance, motor movements or visual sensations. You can also stimulate associative cortex, but then the patient has to perform a certain task, for instance, language or a working memory task. And then you sometimes can disrupt this task. And in that case, we say, okay, that's a positive stimulation, and we mark the place with these tickets here. This seems a very local technique. However, if you apply current to the cortical surface, this current will spread actually into the brain via the white matter pathways. So we think you're actually stimulating part of a network here. So you can stimulate the cortical surface, but you can also stimulate the white matter. So here you see screen from the navigational machine, a malignant tumor in the left frontal lobe. You see the tractographic information in the navigational system, and here you see this blue tract is called the frontal aslant tract, and we think in the left hemisphere it plays a role for initiation of speech. So again, I look through the microscope. This is our pointing device. So we see where we are. We're now pointing to this area here, and once we have identified where we want to stimulate, you will see the bipolar probe, and we start stimulating. In this case, the patient is performing a language task, a picture naming task, and will make errors during this task. And then we say, okay, we're in the vicinity of this tract. We'll consider this a critical tract. We leave it, and this is considered the functional boundary of the resection here. And there, in the end, we'll put in the markers just to document our results. So by many, electrical stimulation, either cortical or in the depth, in the white matter, is considered a tool to identify what's called essential areas. And by essential areas, people usually mean those areas, when damaged, will leave the patient with a permanent deficit. And I will quote this from a paper in Neuroimaging 2011. And these authors, they state, in particular, electrical stimulation allows the discrimination of the essential cortical and axonal areas, which should be surgically preserved, from modulatory areas, which can be activated on non-invasive imaging, but nevertheless removed without inducing permanent deficits. So I think this is a bit too black and white. And I will show you some examples of that later, because I think some tracts matter more than other tracts. I think there's a gradient between a pathway that is really essential and has very low redundancy, and pathway that can actually be removed without any obvious neurological or cognitive deficits. So I'll discuss the optic radiation, the cortical spinal tract, the aqueous fasciculus, and the frontal aslant tract from this perspective. And I think the optical radiation is a classic example of a non-redundant tract. So if you have a lesion, and that's actually very well documented in literature, if you have a lesion anywhere anywhere along the optic nerve, the chiasm, or the optic radiation, you will experience a permanent visual field deficit. So when you electrically stimulate the optic radiation, you know if you damage it, the patient will be left with a deficit. And so here's an example of a patient with a large glial tumor in the parietal lobe, just behind the corticospinal tract and the sensomotor areas, and the optic radiation is really traversing through a part of the tumor. So what we did here, we stimulated to identify the sensomotor areas. We removed this part of the parietal lobe, and in the depth, guided by stimulation, we found the optic radiation. So when you stimulate this primary tract, the patient sees flickerings or visual disturbances. And beforehand, we discussed with the patient where to stop, and we decided that we stop here when we find this visual pathway. So that's the optic radiation. What about the cortical spinal tract? By most clinicians also considered an essential tract. So it runs from the precentral gyrus to the spinal cord. Indeed, there's a strong correlation between damage of the cortical spinal tract and resulting deficits. However, if you correlate damage to the cortical spinal tract and recovery, it only explains about 30 to 40% of variance. So there is a relationship, it is essential, but there's no one-to-one relationship to deficits actually of the cortical spinal tract. So then the occult fasciculus, or the classic language pathway in the left hemisphere connecting frontal and temporal language areas. Here's the famous picture by Catani, who identified a long segment that actually curves around the insula, connects Broca and so-called Wernicke's regions, but they also identified an additional horizontal segment and a vertical posterior segment. And later studies complicated the picture. So there are actually many different connections between the various regions. So it's not a simple picture of the occult fasciculus. The connectivity is much more complicated. And that is probably the reason that there's so much variation and there's not really any agreement on the anatomical definitions of the occult fasciculus. And this is the paper by Schilling, who gave several experts group the same data set and asked them to delineate a number of cortical tracts. And you see the enormous variation between experts even on the cortical spinal tract on top, but also on the occult fasciculus. Is the occult fasciculus an essential tract? At least part of it seems essential, and that is in particular this horizontal part, because damage to that horizontal part correlates to non-fluent speech problems or so-called Broca's aphasia. But again, only in 40% of explains only 40% of the variance of these deficits, and you have to add other tracts to increase that number. So it's probably better to use a network model to predict deficits after, for instance, a lesion or surgery, than focus just on single tracts. And this is work by Lars Smolders from our group. And he is developing models to predict cognitive outcome after brain tumor surgery. And he found that when you correlate the resection cavity and the disconnections that are made during surgery, then you will find a relationship with problems with cognitive flexibility. But if you image the brain 3 months after surgery and then do connectivity analysis and compare that to the preoperative situation, you will find that these changes actually correlate to other cognitive problems. So this seems to be a very promising method to develop prediction models, in our case for brain tumor surgery. So how to move further in a search for clinically relevant regions and tracts, because there's a lot of variation in the different analysis methods. There's variation in, as we have seen, in tract definition, also in clinical outcome measures and surgical monitoring. So that makes it very difficult to compare studies, for instance. So the approach that we have taken is, first of all, to standardize outcome after surgery and before surgery. So Karen Gering did a lot of work here, and now every patient that we operate is tested before surgery, 3 months after surgery, and 12 months after surgery with a similar battery of tests. Second, is that we're now also trying to standardize how we monitor and measure functions during awake surgery when we use electrical stimulation mapping. And Maud Landers is doing that. She developed a protocol to do that we're now spreading along other hospitals in the Netherlands, for instance. And last but not least, for the past 10 years, we've been working in the Technical University and in Tilburg on an automated pipeline for tractography. And here you see output of this automatic system. We regularly use it during surgery to look at these images before surgery and during surgery. And we're actually trusted a bit more than our clinical system that we use from Atomic. And we keep updating the algorithm as compared to the outcome of our patients and findings during surgery with electrical mapping. So that all together allows us to pool data across centers, and that's what we're currently doing. Because of the standardization, we can pool data. And we're now comparing the results from cortical and subcortical mapping to the results of tractography by comparing each of these methods in their own patient-specific space. So despite all this standardization, I think there still remain important challenges. And I think a very good example is the so-called SMA syndrome. SMA stands for supplementary motor area. It's a secondary motor area. It lies just anteriorly to the primary motor cortex. And we know that a lesion or a deficit or surgery within this SMA can really lead to severe motor or language or cognitive deficits, but most of these patients actually do recover. At the same time, with electrical stimulation mapping, either cortically or subcortically, we can find motor, speech, or cognitive networks within the SMA. So despite these positive responses, some of these patients have temporary or even permanent deficits. So the question arises whether or not this is always predictive of permanent post-surgical deficit, and I think it's actually not. So DES, electrical mapping, is not always indicative of only essential structures. And what is actually the reason for that? Why do most of these patients with an SMA syndrome recover? Well, we currently don't exactly know. But the group of Francesco Vaggiani, for instance, looked not only at the frontal ascending tract that you can see here in the lesioned hemisphere, but also in the healthy hemisphere. And they found that when there was a lateralization towards the healthy hemisphere, patients less often had a SMA syndrome. And the group of Baker, they proposed that you can have an SMA lesion, but as long as you leave the callosal fibers to the other network intact, people will recover. So it seems that the network can compensate if you remove part, for instance, of these fibers that arise from the SMA, despite the fact that you can stimulate them. So this is a problem that hasn't been solved, but I think tractography and network modeling will help us understand why some of these patients have deficits and why most of them actually will recover. So what do these surgical interventions in general teach us, or have taught us actually? First of all, I think that we learned that symptoms cannot be fully understood only from damage to a cortical area or only to damage to a single tract. We've also learned that really the white matter architecture shapes the brain function, and eventually brain functions emerge from really distributed networks. I think tractography is really a very, very helpful tool before and during surgery. It really provides already anatomic insight. It supports surgical decision-making, and it generates new hypotheses, for instance. And I think this is a good example, a case study of a patient with a glioma in the left supramarginal region. And what you can see here is the arcuate fasciculus. So that's the long segment from Catani's model, arching around the posterior part of the temporal lobe, the insula, and the horizontal part of the AF, the arcuate fasciculus, which is synonym to the third branch of the superior longitudinal fasciculus. And guided by tractography, we were able to stimulate different parts of this system and found different responses. So this horizontal part gives you phonological errors and a speech arrest, while stimulating the arcuate fasciculus, so the long segment, will really gives you semantic problems. So this helps distinguishing function and anatomy. So here, tractography and electrical mapping work together actually to understand the system. I think, again, this is really helpful. It perturbs the system. We can learn a lot from it. But I think we should be cautious of treating it as a ground truth or function. There's a risk of overinterpretation. I think we also should be focusing more on patient outcome as a true ground truth. We should be careful of equating functions to single tracts, and be careful to translate group findings to individuals and focus more on individual systems and plasticity. So to end, we're really, I think, moving in neurosurgery towards network-based neurosurgery. We have to study the networks more, not only the isolated tracts. I think we can, tractography really very useful in this, as seen as a model of, well, structural constraints and building blocks of these networks. And I really think we should learn from surgery, that we basically could learn from every case that we are actually operating. And it helps us understand how functional networks behave and how they change because of under the influence of pathology, but also under the influence of surgery itself. So this is our moonshot on the left. We're really aiming, I'm hoping in the future, to do virtual surgery. So lesioning the network, see how it behaves, see how it correlates to cognition, to patient outcome, and in the end to patient goals. But that is a long way, but still that's our aim. And I would like to thank all our members of our research group and also the funders of our studies. So thank you for that. And I will stop sharing now, I guess.
Thank you very much for the very interesting overview, and also like a good well, overview of the whole field and like your own research and what people around you in surgery are doing. So that's very interesting. It's always nice to have a summary rather than, you know, like your day-to-day experience. It's nice to have a good sense of what everyone is doing and how the field is evolving. I was really surprised to see even more standardization effort. I'm familiar with the MRI sequence and pre-processing and tractography, and now I learned that there is effort about cognitive outcome, and there is something about direct brain stimulation. So it's impressive to see how many steps need to be standardized to get somewhere. So thank you for this. Yet more standardization. I don't know if there is any question from the crowd or if someone wants to write it in the chat. I have a question on my own. I'm just going to wait a bit in case someone. So if you have a question, you can unmute yourself and just go ahead. Alexander?
Hi, Geert-Jan. Thank you very much for this lovely talk. I have a very pragmatic question about the brain surgery, and so from, let's say, informal conversations with neurosurgeons, that doesn't happen quite often, obviously. Or at least I've learned that when you're cutting into the white matter, then from my understanding, what I learned is that it's more important, obviously, to cut along a pathway than across it, right? It's like thinking of opening a curtain. You can do it gently in one way, right? You can't rip it in the other direction. Is that something that you agree with? Like, do you see it like that as well? Is that information that you take from Tract if you need to cut and damage some collateral pathways? Is this something that you take into account, or is it something that's basically not what you take on board for that?
Well, if you look into the white matter, there's really no structure to be seen. So you can't see the direction of white matter pathways, obviously, also not from the larger pathways. So it's actually a homogeneous structure.
Exactly.
Yeah.
And the tractography does provide you that information. Is there so do you take that on board when you're dissecting, like cutting? Is that something you can do, or you don't or you want to do, or?
No, we use tractography to guide us during surgery. So we're continuously navigating where we are during the resection. And when we approach certain tracks that beforehand we have put in the navigational system, for instance, if we know we are like 5 or 10 millimeters before such a tract, and we know the direction where we're working in, then we start stimulating to find this tract with electrical mapping, so that we continuously oriented where these large fiber pathways are in order not to damage them, actually.
Okay, and so that assumes the function associated with the tract, I guess. Because when you're stimulating, you want to see a response, and I guess that response is functionally dependent, and then you associate that with the tract that you saw.
So, for instance, the example I gave in the beginning of the IFOF, right? So the IFOF, when stimulated, you get language problems, semantic problems. Well, so we ask the patient to do a semantic language task, and then we start stimulating at, let's say, 5 millimeters before we think we encounter this IFOF. And because you apply a certain current, you're actually looking a bit ahead into the brain. And the more current you give, the more you are looking ahead. So, and that is the way that you probe the brain, you probe the resection cavity, and when you don't find a function, you take out a little bit more, and then you start mapping again until the patient is making errors on this task, and you say, okay, now I'm so close to this tract, I will leave it. This is the end of the resection. So that's the functional border of the resection.
Yeah, but you determine this from the functional response, not necessarily from the tract itself, like visually.
No, you can't see a tract. It's all white matter. It all looks the same.
Yeah, but I mean, from in the neural planning system where you see the tractography results, right? So I'm just wondering, I'm always trying to try to understand the surgeon's brain. Like, what are the exact thought processes involved, where I can see that you actually take the benefit from the tractography during the surgery? Because if it's only distance, right?
Yeah.
Then I always wonder, like, well, once you open the brain, everything shifts and the tractography becomes problematic. People argue you need like intraoperative tractography.
Yes, that's the main argument everybody gives, and says that well, you can't use tractography because there's shift. But we use it so beforehand you have a picture. There's the tumor and there's your critical tract in the depth, for instance. So you know when you are approximately going to encounter this tract. So 1 centimeter before you encounter the tract, then you can start stimulating. And you know there's always a little bit of shift. So you take that into account. But then again, the first 90% of the tumor, you know, there's no tract there that I can damage, so you can work quickly up to the borders. There's uncertainty, and then you take that uncertainty into account and start stimulating, and then electrically find this functional border. And in many cases, there's actually only a few millimeters of discrepancy. So the shift is not always the biggest problem. But it's
and I can also
you know the direct,
yeah, and I can also imagine that, you know, because it's not your first rodeo, you can probably do the mental mapping yourself when the, you know, the brain shift occurs and all that you can still have the relative distance in mind of where the tracts are located anyway, right?
Yes, and we know the direction we're working in. So we know, and there's always shift in a particular direction. So well, you still have to come to visit us to see how we work. And
yeah, exactly.
It is really an addition. It is a benefit to have it in the navigational system because you're very much oriented. You know where the particular structures are and when you're going to encounter them.
Yeah. And final quick question, because I realize I'm, you know, monopolizing this, is would it be useful to color encode like the tracts locally with a color encoding map that actually says the distance from the tumor? Like, so you provide color information locally along the tract that indicates the distance, so you get a visual qualitative feel of relative localization with respect to the, you know, position of taking the tumor out. Does that make sense?
Yes, but the instrument that we use to remove the tumor, so that we do that with suction, that instrument is navigated also. So while you're removing the tumor, you're seeing live on your image where you are in relation to this tract, for instance. And obviously that's a preoperative image, but still that gives you a sense of where you are.
Yeah. Okay. Well, I'm gonna stop talking now, but thanks again, and you know, I'll visit you soon in Tilburg.
Yes, I hope.
Thank you for the question. Anyone else with more questions? You can raise your hand or unmute yourself and go. I have a question myself related to standardization of the cognitive outcomes or the direct brain stimulation. I was curious, in our field, even though we are doing just processing, like we're not involved in the risk and the responsibility of like the patients, some people are attached to their processing. They are attached to their pipeline, so they are slow to adapt to standardization effort. And sometimes we try to think about next gen or maybe the next group of people. Is it the same in surgery? Are people quick to adapt to recommendation, standardization effort, or is it really for education and, you know, the younger surgeon that are just starting now?
Well, I think the biggest problem in surgery is not so much, so there are a lot of technical developments, but the biggest problem is to have the surgeon use these new technologies actually. So we're not very used to adapt very quickly in neurosurgery. I think we all love these gadgets, right? But for instance, I think really every neurosurgeon should use tractography because it's anatomy for free. Well, I took what I said to Alexander. It really helps orienting, etc. But still, many surgeons, because they don't know tractography, they're very reluctant to use it. So that's why we think we should develop really a turnkey system for these people, so they don't have to turn to all the buttons. So the commercial system that, for instance, Medtronic gives you has several parameters that you can yourself change, but you don't know what you're changing actually because it's a black box. So I think you should provide a turnkey system to surgeons for that. And then in the end, I hope they're going to start to use it.
Do you think that even if you're in the, let's say, in the middle of your career, you have your practice set up, you think people, if they have such software, they are quick enough to embrace it and to, I know you have a lot of continuous education also, conference that are like, you are expected to go there and learn. So you think if this system exists, people will adopt it?
I think the younger generation that is trained, so the older generation still was trained with this image of the cortex is important, there are the functional areas, and the white matter is not so much important. You stop when you encounter white matter when you operate a brain tumor. So that has changed completely. So now the younger generation actually is trained that this subcortical architecture is really also very important. And then that is when tractography comes in. If you offer them this tool that can visualize these tracts and they know what the clinical value of these tracts are, I think generally this will be embraced in clinical practice. But people have to be trained in that.
Thank you very much for the answer. I see Alexander raised his hand again, so you can go ahead. There is no one that raised
Well,
their
if
hand.
nobody else is asking questions, you know.
Go ahead.
It's related to this. So it's not mandatory, like it's not part of their training, you know, surgeons, they don't have like one of their courses is like, hey, let's look at, you know, these neuroimaging tools and
Less than you would expect.
oh, okay, enough said.
Yeah, yeah.
I also have a question. I hope you can hear me well.
Sure.
I'm talking with, now we use more direct like electrical stimulation to get sort of also a tract with your functions. Does that mean that functional MRI is not useful anymore and we should not be studying functional networks anymore just because we can just connect tracts with their connected functions?
I think functional MRI is very useful actually, because what cortical stimulation cannot do, it can assess momentarily what happens when you stimulate a structure and when you disable a structure. But what electrical mapping cannot do is predict what happens next. So if you damage a part of the brain will adapt over time. And I think we need functional MRI and we need network modeling to predict what happens if we damage the brain. And that is something that you cannot do with electrical mapping. And that is something I hope we can together develop using functional and structural connectivity. So, but I think these techniques should work together, actually. We should build a network model and then try to disrupt it and see what happens. Is that an answer to your question?
Yeah, it is. Thank you.
I have one question as well, if nobody else has any other questions. So I liked your concept of redundancy of white matter pathways. Does this relate to the level of the function that the pathway subserves? So maybe it's naive, but like, do sensory tracts, like are sensory tracts more or less redundant than, for example, frontal projection that subserve like higher cognitive functions? And or has anybody looked into whether the redundancy correlates with the structure of the tract? So we know that some fiber pathways are more topographically organized within, whereas other ones are more like intermingled or whatever. So I was curious if anybody had looked into that.
I think in general, the tracts that arise from primary areas are more critical, so less redundant than from inassociative cortex. That's from clinical and from experience in the literature. But the other question I wouldn't know actually regarding somatotropy, etc. So I think much is still unknown about how redundant actually systems are. And as clinicians, we have these colorful maps. When the area has a color, it's apparently related critically to a function. And there are many non-colored areas. And we used to think, well, damage to that area is from a clinical perspective. For instance, a right frontal tumor, well, the patient has no neurological deficits. What we know now, if we really study these patients with cognitive batteries, these patients do have problems. So I think there's something in between redundancy and non-redundancy. So and that should be mapped and more carefully and more studied more carefully, I think.
Thank you. Alex has his hand.
Yes, but there is also
No, but there's also
in
questions
chat.
in the chat, so I think they should
Oh.
be prioritized. But afterwards, I'm happy to ask more.
Yeah, so there's a question from Jerome in the chat asking if you're using conventional DTI or techniques that attempt to visualize white matter tract within the edema. So it can be, it's about your specific setup, I imagine, when you do surgery.
Well, we have CSD now that we use, and we standardly use the Medtronic system, which has now CSD, and we have our own pipeline, which also uses CSD. And actually, we did quite a lot of tractography in patients with mass effect and edema, and still in most cases, we were very happy with the results. So in the majority of cases, you can still, I think, clinically use tractography in tumors with edema or mass effect. Yeah.
And out of curiosity, like, do you simply say like low FA threshold? Do you do like whole brain tracking and then clean up, or is it manual segmentation of the edema, or a BRAT challenge neural network specifically for edema? How do you deal with it?
We don't have now a specific strategy for the edema. We haven't studied now. I have to be fair. So we use it on the clinical machine, and it's perhaps it's good to so when we started with 4 different tracts, the optic radiation, CST, and 2 language tracts, and we did that because we could validate them during surgery, and then over time we trusted these results. And when we think, well, this tract maybe there may be a problem with this tract, we can always check it during surgery. And that is how we build our knowledge actually over time and adapted our algorithms. And only later we added 3 or 4 more tracts. So we're really working from a standardized protocol. And I often note that surgeons want to use tractography, but only in their very difficult cases with large tumors and edema. So my advice would be, use it every day for every tumor, even if these tracts are not in the vicinity of the tumor, so you get used to it, you get to trust it. And then in the difficult cases, you have a bit more experience.
Thank you for this answer. There is a question from Andrew in the chat asking if there is like a centralized repository or database of surgical outcome for surgeon, for researcher that they could maybe navigate and see like use for research, or is it only for publication, and is it like one surgeon at a time that report their own statistics?
Yeah, there's no repository across different centers or surgeries, to my knowledge, and we now are starting to do that in that multi-center project. Because our monitoring process has been standardized, and we're now discussing with other centers to do it in a similar fashion and to acquire data in a similar fashion. And now we can start comparing outcome and pooling data. But that's only the beginning of these multi-center studies, I guess.
Perfect. And a question from Antoine asking, what do you wish tractography would do better for surgery?
I think the difficulty is not so much now in depicting all these tracts, actually. I think we should discuss together how we define a tract and how we... so the example of all these different opinions about what the AF or the CST is, that is really making our lives very difficult. So one surgeon says, this is my arcuate fasciculus, and the other one says, well, this is my arcuate fasciculus. So we should talk to each other and standardize that. So it's not, it's not the tractography itself. It's how what functions we assign to certain tracts and networks. I think that's the next level that we should be moving to.
Perfect. Thank you very much for the answer. Well, we still have time. Alexander, you can go ahead with your question.
Yeah. So these are very simple questions, but what's the percentage of surgeries that you do where you use tractography? I mean, do you use tractography always, or
I use it always.
You don't?
And we have 3 surgeons who do the awake surgeries, and they want to have this tractography always because we very much rely on it. We use it to counsel our patient. We show them the tractography beforehand, and we use it during surgery. We won't do it without it, actually. So
okay.
Yeah.
And then maybe as a general question, so I'm very happy, obviously, that you're, adopting this new technology. If you're looking at your peers, you're saying like, they're hard to, adapt, like roughly percentage-wise. I mean, probably within the Netherlands, how many neurosurgeons there are. Like, what's the percentage of neurosurgeons in the Netherlands that use tractography then, like you do, or regularly use?
Oh, that will be a very crude guess. I think in
Yeah.
our hospital it's like 50%.
Okay, so half
They
of the
want to use it,
neurosurgeons.
but they want to use it. Well, we've constructed a flow that in all glioma surgeries, this information is available during the OR, in the OR. So they don't have to do anything actually. So the tracks are constructed by other people. So we make life as easy as possible for the surgeons to use it. I think that's a thing you have to do. And then there's still, okay, you have it in the system. Do you really use it, or are you just looking at it? So that's also.
Yeah. Okay.
I think
Let's
50%,
let's say
but
really
not
use it.
everybody.
Let's say really use it. Like look at it and take that on board for your,
Yeah, that is 50% in our hospital.
50%.
Yeah.
And so we're talking about how many
Sorry for that.
neurosurgeons in? Sorry?
Well, we are with 30 neurosurgeons, but I think 8 of them operate on gliomas, and half of them are very fond of tractography, and the other half we're trying to convince.
Okay. So, okay. And then within the Netherlands, roughly, do you know?
I don't
like,
know, really. I think we are, because we are using it for almost 15 years, I think we are a bit ahead of
ahead of the curve.
this technology in the OR and for patients. Yeah.
Okay. Okay. Thank you very much.
I see a question from Flavio. Flavio, you can go ahead.
Hello, thank you. Thanks again for the very nice presentation. I want to ask a question, maybe a little bit tricky, between different categories. Do you think that tractography should be kind of led more by neurosurgeon versus neuroradiologist? Because I was at a conference recently and I got a kind of weird feedback from neuroradiologists saying, "Oh, we don't have time. It's not be refunded by the health system, so we should not waste time on tractography." I find it shocking that they say that, but on the other hand, I know many neurosurgeons, they want to use it. So how we should approach this?
Yeah, that's a difficult problem. And so I think the solution in the end would be to develop an automatic system, because it also solve this problem. It's very labor intensive in the beginning. So I know many surgeons do it themselves, but then you have the variation between people and how they think about the anatomy of different tracts. And many radiologists are actually not trained. They don't have a background in this in tractography. So in our hospital, actually the radiological personnel we've trained to do it. But not the surgeons, because they never have time, and then they're not going to use it. And also not radiologists, because they don't, in our hospital, they're not very interested. So you have to build your own workflow. But I think the ultimate solution would be to automatize it. And then you can bypass all this human intensive labor and also have better definitions, I think, that we all agree about.
Yeah.
What do you think, Flavio?
Well, no, I mean, I kind of end up almost in an argument at the conference. I was kind of shocked at how much resistance there was about from the radiology say we don't want to do that, in the sense that I say, wow, I'm coming from a different experience. I collaborate with a lot of neurosurgeon. I think we know it's working, we know it's useful.
Yeah.
And the fact that simply because it's not being paid or is being refunded by the other system is and then they will start citation. They're like stats that, oh, it doesn't work, blah, blah, blah. But I mean, my point of view is that everyone can do tractography, but it's very easy also to do bad tractography. So the point is, if you know how to do it and you do well, you can see the benefit. That's why we should push that. Yeah.
I will stop the recording, but we can continue talking just to avoid having to splice the video before uploading to YouTube. So I'm just going to record now.